Hello, everyone, and welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. My name is Andrea Bianchi, and I'll be the moderator for today's session. Our speakers today are Daniel Buchman, Brooke Magel, and Iris Coates-Magall, and this seminar is entitled Attitudes Towards Disease Model Explanations of Chronic Pain Among Adults Without Chronic Pain, Ethical Implications for Stigma. Before I introduce today's speakers, I'd like to let you know that this seminar is being recorded. This lecture, along with other archive lectures, can be accessed through the Joint Centre for Bioethics YouTube page. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional lands of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous peoples from across Turtle Island, and I and we are grateful to have the opportunity to work on this land. Now, it's my pleasure to introduce today's speakers. Dr. Daniel Buchman is a bioethicist and scientist in education research at CAMH. He is also an associate professor in the Dalla School of Public Health at the University of Toronto, a member of the University of Toronto Joint Centre for Bioethics, and an affiliate scientist in the Krembil Research Institute at the University Health Network. He is a member of the Canadian Institutes of Health Research, CIHR Advisory Committee on Ethics. Dr. Buchman's primary areas of research interest include ethical issues related to mental health, substance use, and chronic pain, and he has a long-standing teaching interest in empirical approaches to bioethics. Some of Dr. Buchman's current projects explore stigma, chronic pain, and neurotechnologies, cannabis and commercial influences on health, ethics and opioids, ethics and psychedelics, palliative approaches to mental health, and ethics of big data and artificial intelligence. Brooke Magel is a research analyst in the Education Department at the Center for Addiction and Mental Health. She brings lived and learned expertise to research projects spanning the fields of education, health, disability studies, and bioethics. Outside of work, you will often find Brooke enjoying a bubble tea, dismantling the patriarchy on the hockey rink, and pursuing a life goal of traveling to every single continent. And finally, Iris Coates-Magall is a research analyst in the Education Department at the Center for Addiction and Mental Health as well, with a bachelor's degree in cognitive neuroscience from McGill University and a master's of bioethics from Johns Hopkins. Iris's main interests lie in neuroethics, with a particular focus on the social, political, and legal implications of novel neurotechnologies. Daniel, Brooke, and Iris, on behalf of the Joint Centre for Bioethics, welcome to today's seminar. You can take it away.
Thanks so much, Andrea. It's wonderful to be here with members of my team to present one aspect, actually a first aim of a study that we've been working on, exploring disease models of explanations of chronic pain and some of its implications for stigma. Before we begin, I just want to acknowledge some of the artwork that you're going to see throughout the presentation, including the image that we have on our slide here. These are paintings of experiences of individuals' experiences of chronic pain, what it's like for them to live with chronic pain. These images are publicly available that you can access on the Canadian Pain Society website. These were award-winning paintings, I believe, and there's this and many others that you can peruse from various different categories, from lived experience categories to trainee categories as well. The project we're going to talk about today is funded by CIHR. I'm privileged to work with an amazing team on this work, as well as my co-principal investigator, Dr. Karen Davis at the Krembil Brain Institute at the University Health Network and the University of Toronto. I want to acknowledge our incredible lived experience advisors, whose thinking and experiences and expertise in many domains, in addition to their lived expertise, have influenced our thinking and much of the content you will see in the presentation today. That's Esmeralda Burke and Dwayne Patmore. Very much huge amounts of gratitude to Marco Sanchez for statistical support, and we have no other financial conflicts of interest. So For our overview of today, what we're going to talk about, we're going to give a little bit of background. I'm going to give the overview of the present study that we're going to talk about aim one of the study, in which the results we're going to share with you today, some limitations, a discussion about what we've presented, and then identify what our next steps are, which include the second aim of the project, and then provide a summary. So what is chronic pain? Well, chronic pain is often defined as pain that persists for longer than at least 3 months. Chronic pain is often considered to be very multifactorial, incorporating multiple elements, such as biological elements, psychological, and social factors. And this is sometimes referred to as a biopsychosocial model. Recent estimates suggest that at least 1 in 5 Canadians live with chronic pain, which is a huge amount. These are numbers that are very similar to sometimes what we see about numbers of people who are living with mental health conditions. So approximately 20% of the population lives with a chronic pain condition. And chronic pain is often understood or described as an invisible and subjective condition. So what does that mean? So on the one hand, there is not necessarily a relationship with any sort of perceived or identified pathology, let's say on an X-ray or a CT scan or an MRI, and the reported pain intensity by the patient. Sometimes there is evidence of pathology and the person doesn't necessarily report much or all pain. And also pain is considered a subjective condition. So pain is whatever the person says it is. I may sort of experience some pain and rate it, on a 10-point scale as being a, 8 out of 10, or someone perhaps with the same ailment might rate it as a 3 out of 10. The experience of pain and what it's like to live with pain is also inherently subjective. But this presents a lot of challenges for our contemporary society within biomedicine. And in biomedicine, we have a focus on material indicators and pathology of disease states. And so this is what sometimes is referred to as medicocentrism in our society. So we look for signs and symptoms of disease, and these things that are identified through, like say, medical tests or scans, are privileged epistemically than typically what the patient's reports are. Right? So we want to invite the patient to tell us what it's like to live with pain, but typically, because of this culture, we're looking very much for these signs and these objective signs and symptoms. And this has made sort of the lived experience of pain for many people, as we know from folks with lived experience, but also from the literature, as this is a very often frustrating and demoralizing and delegitimizing process when their experiences don't necessarily correspond to objective physical signs. And this has also motivated a massive and very important program of research in brain imaging, where researchers are actively looking for the presence of pathology or brain-based biomarkers to help diagnose, prognosticate, and treat chronic pain, or chronic non-cancer pain. And this has also motivated people with lived experience and activists and advocates and clinicians and others to consider chronic pain as a disease in itself. Because the idea, given sort of the medicocentrism that we have in society, is if we could only somehow legitimize chronic pain as a disease in itself and not as a symptom of another condition, we would reduce stigma, patients will, have better access to treatments and so forth. And so we see this actually, in the literature on pain. And so here's some recent examples. There was a landmark report on relieving pain in America by the National Academies of Medicine, formerly called the Institute of Medicine, and which states very clearly that some types of chronic pain are diseases in its own right. We have seen in the recent revision to the International Classification of Disease, the ICD-11, where there's 2 types of pain, chronic primary pain and chronic secondary pain, and where chronic primary pain is considered a disease in itself. And we've seen this too. There's some wonderful mobilization happening in Canada around amplifying the importance of the public health challenge of chronic pain. And the Canadian Pain Task Force too said in its 2019 report that chronic pain is a disease in its own right. So these very, authoritative organizations are using the language of disease to describe chronic pain. And there may be some benefits of doing so. Well, what we know from other medicalized conditions is that when there is a disease model of chronic pain, or a disease model of the condition or an explanation, it legitimizes it. And this is particularly helpful within a medical culture and when there's contested conditions or conditions that are, have a lot of uncertainty, or there's uncertain signs and symptoms and we're not quite sure what to do. And so this may lead to increased research on the particular condition, as well as funding and allocation of resources. And ideally, and as was hoped with other disease models like substance use disorders or addiction, is that if we could only understand addiction, for example, as a brain disease, it should lead to ideally more compassionate treatment and policy responses. Because if it's considered a disease, or at least a brain disease, the person should not be held responsible for their condition. It's not their fault. And ideally, this would also help reduce some of the stigma that's attached to these conditions. But there's also some ethical vulnerabilities of disease models. And particularly in brain disease of addiction models, we see some concerns around neuroessentialism. So the idea that you are your brain. So the modern, our identity in our contemporary culture and contemporary Western culture, is in our brain, makes up who we are, as opposed to, maybe the ancients would talk about the heart as the seat of the soul. Our brain is actually our seat of our soul. And so who we are is how our brain is, and the folk psychology that we might use to describe our experiences, like, the adrenaline you get from going for a run, or the dopamine hits from social media. And so the idea here is that if somehow, who you are is how your brain is, if you have a diseased brain, that might mean also that you are diseased. And this could lead potentially to increased stigma and social distance. And so we've seen some evidence from other conditions where there is a mixed bag for disease or even brain disease explanations of conditions like addiction or mental illness. So for example, you may have reduced blame and personal responsibility for your condition, but as a result, you may actually have increased fear. And increased desire for some other aspects of what's called social distance. So it's could be like a potentially mixed blessing where some aspects of stigma are reduced and others are increased. And two, at a very narrow sort of reductionist focus on the brain or on disease models may come actually at the expense of broader public health approaches in terms of prevention. And it could also happen, for example, what my Australian colleague Wayne Hall has talked about in the context of addiction, a disproportionate focus on great and desperate cures. So somehow, if we understand, something like addiction or chronic pain or mental health very biomedically, we may, as a society, devote a disproportionate amount of resources into curing many of these chronic conditions, which can be using very sort of expensive technologies that may present sort of other equity access issues, in all the major urban centers, high cost to health systems, and so forth. And so the similar assumption here is what we might be seeing in the literature on chronic pain is that disease models, or even brain disease models specifically, will decrease stigma towards people who have lived the experience of chronic pain. And I think this is a really important empirical question. What we do know from some of the research on medical explanations on pain is that when in vignette studies, when participants are given a description of someone with a medical explanation versus a non-medical explanation of pain, on various scales that participants report on social comfort and desirability, patients and people who are living with pain are actually more likely to be socially excluded when their pain has no medical explanation than when it does. And as I had just previously mentioned on the other slide, we can look to other conditions and evidence where, there is these unintended consequences for stigma on disease or even brain disease explanations. So we see this in addiction. If you look at some of the literature on genetic or biological explanations of mental health and mental illness, and particularly in neuroscientific explanations of mental illness as well. So really, what we wanted to know in this study is what is the relationship between these emerging disease or brain disease models of chronic pain that we're seeing in the literature and its relationship to stigma. So I'll hand it over to my colleague, Iris.
Hello, thank you for that, Daniel. Yeah, so for our study, we decided to utilize a two-part mixed method study in order to sort of tease apart these three interrelated concepts and phenomena that Daniel just talked about. The first, which we have already conducted and are working through the analysis for, is AIM-1, which is a contrastive vignette study, in which we wanted to investigate the effects of a brain disease explanation of chronic pain on the degree to which people without chronic pain stigmatize those who do live with chronic pain. So this is looking more at the sort of general lay audience. And then AIM-2 is we are looking to get a little bit more nuance into that with a qualitative interview study, exploring the influence of a brain disease explanation on stigma with people who both live with chronic pain and their healthcare practitioners who tend to treat chronic pain. So next slide, moving on to AIM-1. We had participants from the US and Canada who live without chronic pain, recruited through Prolific, which is an online recruitment tool. The inclusion criteria were that you had to be over 18, live in Canada or the US, and have never lived with chronic pain. So participants would first complete several scales and read a plain language definition of chronic pain, and then each of them would be assigned one of 5 different vignettes. And then complete the, and so if you want to go to the next slide. So we crafted this vignette about Sam, and Sam is a 48-year-old store supervisor who has been living with chronic pain for a while and sighs and winces throughout the day. Sam's physician orders a few medical tests for further investigation. Based on the findings of the test, the physician suggests one of 5 different explanations for the source of Sam's chronic pain, which, as you can see in this chart, are no physical cause, a sort of biopsychosocial explanation of an interaction of biology and psychological factors that are the cause of the pain, a disease model, specifically a brain disease model, and then finally explained by a brain disease model augmented with visuals of neuroimaging, so pictures of the brain. And we wanted to just quickly emphasize that we developed this process or this vignette in a very iterative process, and we did a lot of pilot testing. If you want to know more about the procedure that we used to develop those along with the people with lived experiences, we'll be happy to address that in the question and answer period. But what we like to point out about this is that we purposefully made the name gender neutral because we wanted to see if there were potentially different ways that people approach people with chronic pain differently based on gender. Next slide. So what would happen is we would give someone one of these 5 vignettes to read, and then we would give them a number of questions based that sort of are a proxy measure of stigma. And one of those is an adapted social distance scale. So the social distance scale is a 6-item validated measure where participants rate their willingness to interact with someone in various interpersonal situations. So they define social distance as the degree to which one person is willing to interact with a target person in different types of relationships. So as you can see from these questions, there's such things as how would you feel about Sam renting a room for you? From a scale of 1, definitely unwilling, or sorry, 0, definitely unwilling, to 7, definitely willing. Or how would you feel about Sam looking after your children? So on and so forth. The social distance scale has been commonly used as a proxy measure for mental illness stigma, as well for obesity stigma. But to our knowledge, this social distance has not been used as a proxy for a measure of pain stigma. So if we want to move on, I will to the next slide. I will briefly show some of the demographic results that we got before Brooke goes into more of the meat. So we did various tests to see if there were any significant correlations between stigma, vignette, and different demographic variables, with the objective to investigate how individual demographic variables may have moderated the effect of the vignettes on social distance. So our initial descriptive analysis was conducted using means and percent and calculated p-values and effect sizes as a descriptive way to report differences across different randomization groups. And just some of those that you can see that fairly evenly split between men and women respondents. 56% of respondents were under 35. Over 80% had at least some undergraduate education. Roughly 60% self-identified as being white, and there are about a 2-to-1 ratio of American respondents to Canadian respondents. And one interesting thing that I'd like to point out is the political leanings bar graph that we have here. And why we asked about politics is because we see a relationship between the far right and increased ratings of stigma or social distance. And all this shows is that there is, in fact, we tend to have a fairly left-leaning sample. So that's just something to keep in mind when we go through the different results, is that in general, our population leans a bit more right, and that might have an effect on the other results we see. So that's it. So on to you, Brooke.
Thank you so much, Iris. So on this slide, you will just see our AIM-1 results of a Kirschkow-Wallace test. And this is a non-parametric test. Since our data was not normally distributed, we mostly had ordinal data points. So here you will see 9 different variables. And what I want to just draw attention to is the variables in yellow. So these are variables that we did see a significant difference for. And these variables show that there is differences between vignettes for these specific variables, but not necessarily, well, it does not in fact show where the differences lie. So here you will see that there was a difference between vignettes for how much pain Sam was in, for a p-value of 0.004, for how much sympathy participants had for Sam, and a p-value of less than 0.001, as well as how willing participants were to help Sam with daily activities, for a p-value of 0.024, and also for how much they thought Sam was telling the truth about their chronic pain, with the p-value of less than 0.001. And the last significant difference between vignettes was for how likely participants thought that Sam was exaggerating their chronic pain, for a p-value of less than 0.001. The other variables that you see here did not result in a significant p-value, although I will draw attention just to the last column, which was the social distance scale composite score that Iris was talking about previously, and that did not warrant a significant result. So on this page, after you do the Kirschkow-Wallace test, you typically do a different test. And in this case, we did a Mann-Whitney-U test to see where the differences between groups lie. And this was conducted for the first variable, which was how much pain Sam was in. So here on this slide, you will see that there was significant differences between vignette of no physical cause and the disease model vignette. And the effect size for this difference between groups was calculated using Cohen's d, which resulted in a effect size of 0.517. And this is considered a medium to large effect size. We also saw a difference between the no physical cause and brain disease vignette, which resulted in a Cohen's d effect size of 0.297, which is considered a small effect. So what you can conclude from this is that when Sam's physician suggested that Sam's chronic pain was due to a disease or a brain disease, our participants thought Sam was in more pain than when Sam's physician suggested that Sam's chronic pain had no physical cause. And on this next slide, you will look at the variable of how much sympathy did participants have for Sam. And when we did between group comparisons, we did see significant differences between these two different combinations. So for the no physical cause vignette and the disease vignette, we did see a significant difference for an effect size between the groups, resulting in 0.561, which is considered a medium to large effect. We also saw a difference between the no physical cause vignette and the brain disease biomarkers and image vignette. And the effect size for this difference was 0.439, and this is considered a small to medium effect size. So what we can see from this is that when Sam's physician suggested that Sam's chronic pain was due to a disease or a brain disease and biomarkers, including the image, participants felt more sympathy for Sam than when Sam's physician suggested that Sam's chronic pain had no physical cause. On this next slide, you will see the significant values for the variable of how willing are you to help Sam with daily activities. So the significant differences between vignettes lied firstly in the no physical cause and disease vignette, in which we saw a Cohen's d effect size of 0.436, which is considered a small to medium effect. We also saw differences between the no physical cause and the biopsychosocial vignette, and that resulted in an effect size of 0.317, which is considered a small effect size. Lastly, we saw differences between the no physical cause vignette and the brain disease biomarkers and image vignette, resulting in an effect size of 0.293, which is considered a small effect size. So what we can conclude from this variable is that when Sam's physician suggested that his chronic pain was due to a disease, biopsychosocials, or a brain disease and biomarkers, including the image, participants were more willing to help Sam with daily activities than when Sam's physician suggested that Sam's chronic pain had no physical cause. On this next slide, we're looking at differences in Sam's exaggeration of chronic pain, and we saw significant differences between 3 different vignette combinations. And the first one was the no physical cause vignette and the disease vignette. And this resulted in an effect size of 0.659, which is considered a medium to large effect size. We also saw a difference between the no physical cause in the brain disease biomarker and image vignette. And this resulted in a Cohen's d effect size. Well, the effect size was calculated using Cohen's d of 0.412, which is considered a small to medium effect size. So what we can conclude from this is that when Sam's physician suggested that Sam's chronic pain was due to a disease or a brain disease and biomarkers, including the image, Sam was perceived to be less likely to exaggerate their chronic pain than when their chronic pain was suggested to have no physical cause. Lastly, on the slide, you can see that there was a difference between the biopsychosocial and disease vignettes, resulting in an effect size for this difference between groups of a value of 0.392, which is considered a small effect size. And we can conclude from this is that when Sam's physician suggested that Sam's chronic pain is due to a disease, Sam was perceived to be less likely to exaggerate their chronic pain than when Sam's physician suggested that Sam's chronic pain was due to biopsychosocial factors. Lastly, for the Mann-Whitney-U test, the last variable that we looked at that was significant from the Krishkal-Wallace test was how likely do you think Sam is telling the truth about their chronic pain? We did see differences between 4 different vignette combinations. So firstly, we saw a difference between the no physical cause in the biopsychosocial vignette, resulting in an effect size of 0.465, which is considered a small to medium effect. We also saw this difference between no physical cause and disease vignette, and this resulted in an effect size of 0.660, and that is considered a medium to large effect size. We also saw differences between the no physical cause and the brain disease for an effect size of 0.434. And lastly, we saw a difference between the no physical cause in the brain disease, biomarkers, and image vignette. And this resulted in an effect size for the difference between these groups of 0.437. And this is considered, again, a small to medium effect size. And what we can ultimately conclude from this last variable that I will be showing you from the Mann-Whitney-U test is that when Sam's physician suggested that their chronic pain was due to a disease, biopsychosocial factors, a brain disease, or a brain disease and biomarkers, participants thought that Sam was more likely to tell the truth about their chronic pain than when their chronic pain had no physical cause. So on this next slide, I know we just went through a lot. So there was, I've just quickly summarized the comparisons of the variables to the no physical cause vignette. So what we can quickly conclude here is that when Sam was perceived to be in more pain, Sam was perceived to be in more pain when participants saw the disease vignette or the brain disease vignette compared to the no physical cause vignette. Sympathy towards Sam was also higher by participants when participants viewed the disease or the brain disease biomarkers and image vignette when we compare this to the no physical cause vignette. Participants were more willing to help Sam when they viewed the disease, the biopsychosocial, or the brain disease biomarker and image vignette compared to the no physical cause vignette. Participants also thought Sam was less likely to exaggerate their chronic pain when they viewed the disease, the brain disease model, and biomarkers and image vignette compared to the no physical cause vignette. And lastly, Sam was ultimately viewed as more likely to tell the truth about their chronic pain when they viewed the remaining 4 vignettes compared to the no physical cause vignette. So what I am just going to get to now is the results from our linear regression models. And this specifically, we were looking at, the objective here was to investigate how these individual demographic variables may moderate the effect of the vignette, specifically on the social distance score, since that was what we were primarily looking into. So here, we did not see a difference in social distance scores between vignettes related to the following demographic variables provided by participants. So this included participants' age, participants' gender, the country from participants, which was either Canada or the US, area type. So this included urban and rural, and also political affiliation. So this was the scale in which Iris was talking about previously, in which participants self-identified if they were more left or more right-leaning, and if they knew anyone with chronic pain, as well as their familiarity with chronic pain, and also Sam's perceived gender, since, as Iris previously mentioned, we are very intentional in making decisions about Sam's gender in order for Sam to be perceived as gender neutral. So as I previously mentioned, there were not many statistically significant results from these linear regression models. However, I just want to draw attention to the interaction between the political affiliation, vignette, and social distance. So as I said before, we did not see much evidence that political affiliation moderates the vignette effect for social distance. However, the reason we included this on our slides today is we did notice a kind of an interesting trend in the data. So for every data point increase in right leaning of political affiliation, there was an average 4% decrease in social distance score. So there was a decrease in social distance score, which means that they were 4% leaning towards higher social distance. The next interaction I just want to draw attention to was the interaction between education, vignette, and social distance. So specifically, we have grouped these categories into educational attainment for some, college or less. The middle category is for folks who have completed college or an undergraduate degree, and the column on the far right is master's degree or above. And this was comparing the interaction between vignette, educational attainment, and social distance score. Could you just go to the next slide? So on the slide, we don't see much differences, and there's still no specific patterns are clear. However, I just want to draw your attention to the interaction for education level of college and undergrad, because across all vignettes, there was some evidence of moderation, but not too strong, in which that participants had higher social distance scores. Lastly, as previously mentioned, we kept SAM's gender neutral in the vignette. And we made a really intentional decision here to ask one final question in the survey that participants filled out, which was, what do you think SAM's gender is? Participants did not have the opportunity to go back to reread the vignette after they saw this question, because we really wanted to elicit some feedback about whether or not our plan worked of making SAM truly gender neutral. And as you can see here, our plan did not really work. So 81.5% of respondents thought SAM was a man. And I think these findings are particularly interesting, which is why we included them here today. And I think this points to a concept in sociology, amongst other disciplines, of men as default unless otherwise indicated. And this really stems from this idea that men are the human default of the structures of society. Maleness is often implicit, maleness is unquestioned, it is default. And also, this is particularly interesting given that a lot of research indicates that most chronic pain conditions, in half here, half of chronic pain conditions are more common in women. And in the Canadian context specifically, 18% of Canadian women suffer from chronic pain compared to 14% of men. Lastly, this research also shows that chronic pain reported by men is seen as more legitimate than women, and healthcare professionals tend to discount women's pain more than men. And this could be a possibility why participants thought that SAM was more likely telling the truth about their chronic pain, since 81.5% of participants believed that SAM was a man. Lastly, I just want to acknowledge limitations with this study. So this study was a contrasted vignette technique study. So it's important to note that although there was some differences in the data, are they meaningful to real world contexts? And this is something that we really need to be cautious about. Participant bias is also important here, specifically social desirability bias. And this is a response bias in which people have this tendency to want to answer questions that would view them in a favorable light. So they may over-report good behavior and under-report some undesirable behavior. However, this is very common in self-assessments. And this could also be the case given that we did have a relatively compassionate sample, as you probably saw, based on our results that we shared today. Importantly, there is also the risk of survey error. So disease explanations of chronic pain is a very new concept around, as well as language around biomarkers. Some participants may not know what a biomarker is, so this is also something to take into consideration. So this leaves us with an important ethical dilemma. Since we saw very little difference in our social distance score as a proxy for stigma, as well as our other stigma-related variables, should we still consider the possibility of using disease explanations of chronic pain to guide anti-stigma interventions? And we have some really important key considerations here that I really think we need to be looking to other disciplines and other literature, such as critical disability studies, in which I can hypothesize that if we use disease models and explanations of chronic pain, similarly to the medical model of disability, could this abstract the person and their chronic pain from social and historical contexts and start to privilege discussions of medicalization and curing chronically ill bodies? Could this further ignore contextual factors such as the social determinants of health? Daniel also talked about earlier what we know about brain disease explanations of addiction, and they found that it could actually increase stigma and also frame conditions, and the framing of these conditions can severely impact the quality of life and the care of people with lived experience. Lastly, we really need to consider existing research on stigma and whether or not disease explanations should guide specific dimensions of stigma, such as public stigma, structural stigma, and internalized stigma. And ultimately, this ethical dilemma really underscores the importance of testimonies of people living with chronic pain to explore some of the nuances of disease explanations of chronic pain on stigma. I will now hand it back to Iris to end our presentation today.
Thank you, Brooke. So we started out with AIM 1 with a slightly more looking at the status of the way people approach people with chronic pain as it is now, but we're left with the normative question is whether or not we should use a brain disease model in anti-stigma efforts. So in order to approach this, we have AIM 2, which is a series of qualitative interviews to ask the research question, what is the meaning and significance of a brain disease model of chronic pain for stigma for those that, one, live with chronic pain, and two, they're healthcare practitioners who treat people with chronic pain. So we are conducting semi-structured interviews with these two groups and asking them questions, probing their values and what is of moral importance to them. Recruitment is currently underway. So far, we have about 15 people with lived experiences who are scheduled to interview with us. And we're going to be using a qualitative description research design with a theoretical framework of hermeneutic of phenomenology and Kliman's theory of moral experience, both of which tend to look more at ethical dilemmas as being rooted in individuals' own individual values, rather than these sort of preset, quote unquote, sticky ethical dilemmas that are fairly intractable. Next slide. Yeah. So to sum up, it's unknown whether or not disease models of chronic pain may impact stigma. More research is needed to explore if we should use disease models of chronic pain in anti-stigma interventions. And we're hoping that these interviews that we will be conducting give a more nuanced understanding of the effects of the way that we frame chronic pain as a disease or not and where it's located. And I believe we're open for question and answers. So thank you all very much for listening to our talk, and we hope you found it interesting.
Wonderful. Thanks so much to each of you for taking the time to share your research with us. So given that it is the end of the presentation time for Q&A, I just want to note that folks who are attending can certainly put a question or a comment into the YouTube chat if you haven't already. If you aren't logged into YouTube or if you want to ask a question anonymously, you may also send your question or comment to jcb.ea@utoronto.ca. And I believe that this email address has been posted in the YouTube chat for those who are joining there. All right, so to kick things off, so a couple of questions, and I also have a couple of questions as well that we can hopefully get to. So I think that this might have been Iris at the beginning who mentioned that the vignettes were developed in a particular kind of way. Can you just say a little bit more about how they were developed as mentioned at the beginning?
Yeah, Brooke, would you like to take that? That was before my time here.
Yes, I can certainly take that. So our vignettes were developed specifically to consider, as we mentioned before, controlling for gender neutrality. So what we did, specifically looking at gender, is we asked our colleagues in our department, what are some gender neutral names you can think of? We also considered ethnicity as a consideration, and we ultimately used their feedback to create a survey in which we rank ordered different names from what people perceived as most gender neutral to least gender neutral, although obviously there are some contested reasons behind why people may perceive one name to be more gender neutral than the other. Speaking specifically again to the gender neutral piece, we also look to Stats Canada for a gender neutral job for SAM. And a store manager was a gender neutral job that was reported by Stats Canada for between men and women. So looking beyond just the gender neutral piece of the vignettes, these vignettes were modeled after vignettes that were conducted by De Ritter in 2016. And we did a lot of pilot testing with these vignettes, specifically looking to ensure that these vignettes did have plain language, because that was increasingly important given that we were speaking directly to, we were providing these vignettes specifically to the general public. So these went through multiple iterations with our research team. We also had the people with lived experience advisors on our team go through and look over the vignettes to ensure that the language was easily understood by folks in the general public. So we did go through multiple iterations, and this was something we spent many months on to ensure that we really had this down, because this is one of the most important steps in research, is really the design process and ensuring that we've accounted for all these multiple dimensions to make sure that our vignettes really and truly were well thought through. Daniel, do you have any else to add?
No, not too much to add. Just one clarification point around the job. So as Brooke mentioned, it's not that the job itself was gender neutral. It's that on Stats Canada, they're reported sort of a in terms of a gender binary, sort of close to equal proportion of men and women tend to have the store manager position. So we chose that for that reason, just to not to say that some, because it is true that some professions are perceived to be more of, for one gender or another. And that, I think what I've benefited a lot from this process, as Brooke mentioned, it took a very long time. And I think that's important, that we wanted to make sure that it was clear, that the vignettes were easy to understand, that they had sort of that face validity. And also that people who are living with chronic pain would read it and be like, okay, absolutely, that actually describes sort of what it might be like for me, and the importance of the contrastive piece in the vignette. So as Brooke and Iris mentioned, participants were randomized to one and only one vignette. And the only difference, as was mentioned on one of the slides, was that brief explanation of pain. Everything else was the same. So we wanted to see if there was an effect of that experimental manipulation.
Thank you so much for the information there. Okay, so the next question, but I'm going to elaborate a little bit on it. So I particularly found it incredibly interesting, but also concerning to consider some of the results that you found, specifically that physical causes for pain, but really for any of the results that you explored resulted in more sympathy for Sam, or resulted in more willingness to help, these sorts of things. And so I'm curious to know if that is similar to what has been found in other similar kinds of studies, assuming other similar kinds of studies have been done. So I guess that's one part of the question, is if it is reflective of other studies. And then the other part of the question is, what do we actually do about it? There's obviously more work to be done, but what do we do just knowing that this is a thing?
I'm happy to start, and then Brooke or Iris, if you want to jump in as well. So to Andrew, to answer your question, yes, in where you do sort of see this mixed bag model, or mixed bag model of stigma for other contested conditions. And I think maybe if I'm picking up on what you're identifying as concerning here, is that Yeah, so consistent with other studies, especially around medicalization or medical explanations, is that when you have something like pain or other contested conditions that are medicalized, there's increased sympathy. So on the one hand, you think that's great, right? But that means that people who aren't afforded medical explanations, or especially up until now, perhaps have not been receiving the same level of sympathy or even other sort of related emotions such as compassion and empathy as they ought to. Right. We also saw that with an increased pain rating. So somehow people perceived SAM as being in more pain than with disease or medicalized explanations than others. And again, that's sort of consistent with sort of the medical legitimacy that these explanations afford, which, you know, in a sort of contemporary medicalized or biomedical culture, that helps. But without some of those explanations, people, as we know, living with chronic pain or other chronic conditions aren't afforded that sort of same kind of consideration. And so if it's more real or it's more medical, therefore they must be in more pain. And I think, you know, there's been a lot of really important work on critical disability studies and disability ethics that has looked at medicalization and perceptions of sympathy or similarly of pity, which is problematic, you know, considering who's sort of afforded these kinds of ideas in society and not others. So, so it is in some ways consistent with that. And I also want to say that, you know, we know from other qualitative work around like mental health or substance use is that people who are living with these conditions do want that medical legitimacy because they've had their testimonies undermined, because they've received poor quality of care, because that they, you know, are not taken seriously by healthcare professionals or their friends and family. So they desire for this medical legitimacy of their experiences, which is unfortunate that people can't be taken at their word or believed or taken seriously when they say that they're living with pain or they're living with X, Y, or Z. And that it needs this type of explanation in order to be perhaps treated in a compassionate way. I don't know, Brooke or other Iris, if you wanted to add anything.
Okay, thank you so much for that explanation. And you were bang on, Daniel, in terms of why I used the word concerning as part of my initial description there of the question. Okay, so another question is just, can you repeat what you had mentioned, I think at the beginning, about chronic pain being a disease in itself? Chronic pain is a primary diagnosis versus secondary. And then if chronic pain is a disease in itself, then would this maybe result in more of a willingness to help Sam if there isn't another known physical cause?
So I'll just sort of say the latter part first, which is I think we did see some effect of a sort of willingness or more, at least more sympathy towards Sam with disease or brain disease explanations. There was not a lot of significant results on other areas and dimensions of social distance, but I think sort of the motivation, and maybe to answer the first part of the question, the motivation behind disease and brain disease explanations is that, you know, it will offer that medical legitimacy that people desperately seek because they're not receiving that and they're suffering, or at least many people are suffering with that. So I think when I mentioned sort of different types of pain, what that refers to is the International Classification of Diseases, the 11th revision, recently changed its classification criteria into primary pain and secondary pain. And the primary pain is pain that is considered a disease in itself. And this is the long work of advocates. This is the long work of people living with pain, healthcare professionals, family members, and other scientists, and really trying that are looking at, you know, making pain legitimate or a disease in itself, because often in our sort of culture, again, back to sort of the contemporary culture of biomedicine, when things don't have those corresponding physical signs, they're often dismissed or not taken seriously, and people are left sort of living with pain. So I think that is the fruit of those efforts over decades and centuries. I mean, pain is a ubiquitous human condition, and you know, we have at least 20% of the population living with chronic pain. So so it doesn't mean that's necessarily a bad thing. I mean, I think there's a lot of benefits to that, but we also seen from other cases some unintended consequences. So I think what we're picking up on is in the medical literature, in the scientific literature, people using disease explanations of chronic pain to describe it, or sort of saying chronic pain is a disease in its own right, which means like we should take it seriously. And I would argue, yes, we absolutely should take it seriously, whether or not we consider pain a disease in itself.
Thank you so much. I have a question that I jotted down, if you're okay with it, given that we have a couple of minutes left. So the question was actually around the political leanings and stigma. And just you mentioned that this has some connection, and it was mentioned that this comes out in social distance measurements. And I thought that the results of that were also quite fascinating to reflect upon. I was just curious as to whether political leanings and stigma have been studied in relation to pain specifically, or in relation to mental health stigma or other types of stigma that may exist, because that is something that I didn't anticipate being asked about necessarily when you were going through the various pieces of information that you asked respondents to provide. So I thought that was incredibly interesting. We'd love to learn a little bit more about the connection.
Anyone want to go? Am I going again? Brooke, you want to jump in?
Go ahead.
Okay. So we did not find, and then you'll fill in the blanks. So we didn't find a statistically significant effect on political affiliation. What I think Brooke mentioned is that there was a trend in some of the data where we noticed as participants self-identified political leanings went farther on the right end of the spectrum. There was an increase in desire for social distance. So overall, it wasn't statistically significant, but it was sort of a trend that we noticed within the data. I'm blanking a bit offhand on other sort of aspects of literature, but what I'm sort of recalling is that I don't think it's been used before in a pain context. But I think one reason why we decided to include it is, and Iris I think mentioned this, is that there tends to be a relationship between political leanings and support for example, like punitive drug policies. Or so there's a major studies on mental illness and substance use from the U.S. and the General Social Survey, which I believe looked at political leanings of like thousands and thousands of U.S. participants and found that, I think, if I'm getting this correct, is sort of the more that you identified as being on the right end of the political spectrum, the less supportive you were, and maybe endorsed more more harsher policies for substance use or laws for substance use, as an example. So we wanted to see if there was something similar to pain. We didn't identify it at least in our study, but it's entirely possible. As I think, as we also saw, and Iris mentioned, our sample tended to be more on the left side of the political spectrum, or left of center, and weighted more heavily that way. So that could help also explain some of the results that we had.
Yeah, very much has. And just personally, I think that's interesting research to look into that I hadn't at all. I didn't know that there was a connection there, though it's unsurprising that there may be for some of the examples that you gave around the punitive drug policies. Thank you. Was there anything else to add in relation to that point, or anything else? No? Okay. That sounds great. Well, it is 4:58. Hopefully my clock here is accurate. And so it is time to draw today's seminar to a close. I have a couple of announcements to make before we officially or formally thank our speakers. So our next is on November 15th, featuring lecture series on ethics and governance of artificial intelligence for health with visiting professor Dr. Alex John London. More details will be posted on the JCB's Eventbrite page. To sign up to receive our weekly seminar reminder and event digest emails, please email jcb.info@utoronto.ca. And I think this is being put into the YouTube chat now, if it hasn't already, so feel free to email them there. And Daniel, Brooke, Iris, on behalf of all of us at the JCB, those who are attending, those who will inevitably watch the video and afterwards, just thank you very much for your presentation. This was wonderful.
Thank you so much for having us.
Yeah, thank you.
Thank you.